I mentioned that in the previous talk, that early on in my career as an addiction psychiatrist, that when I moved from Syracuse to Pittsburgh, Frank, has been really, is an amazing, mentor, and in a sense he introduced me to really Western psych, but also particularly to what could be done, in the addiction division there, because there wasn't much at that time 18 years ago, and he was like a huge advocate for really expanding the services there, and major support. I really appreciate it very much, Frank. Thank you. All right, so I like to I'm going to try to see if we can have a little bit more time, but maybe 10-15 minutes for any questions or comments, and a little bit of an interaction, and I'll try to really go through this as really not as quickly as I could, because obviously what I'm reviewing here with the motivation interviewing, we're talking about really a 25-year, evolution of where we were back in the early 90s. And in fact, I look back at my career early on when I was in residency training back in Syracuse, and where I didn't have much exposure to working with patients with addictions at all. And to the first really, time when I was introduced to motivation interviewing by one of my mentors at the VA then in Syracuse, and back in '91 when the first edition came out, at that time, obviously it was not the approach was not disseminated, in behavioral medicine in general, but it was mostly really confined, to the addiction world. And not a lot of studies, obviously very limited then, but the approach was a little bit of an unusual approach in the field of the addiction at that time, and even, in the field of behavior change. And it was really fascinating, because I strongly believe from that moment, when I was introduced to it and I started practicing and getting the supervision, that really my whole career has really evolved, and my work in the field of addiction has really, progressed to a point where made me obviously more passionate and more really involved. And I look at it as really more the catalyst for me to really trigger my career at that time. This is from the 1991, the first edition of the book. When you read in the preface, they talk about the fact that there is a word of informed consent, which is this approach is likely to change you. And in fact, I look back, this approach has really changed me, totally. And also what the focus was in that, if you go back to that early edition and read in the preface about what it was meant by that this approach is like to change you, the Bill Miller and Steve Rolnick, and the pioneers of motivation interviewing, talk about really the importance of really humility in the work, with patients who have addictions. And talking about the approach is really has such an impact, is so powerful to help people change their behaviors. At the same time, we need to always keep ourselves grounded in, yes, this approach is so powerful, at the same time, we need to stay grounded and really very much humble about how we're going to utilize this approach. We are not really using this approach to, again, coerce or push people. Obviously, we're introducing this approach from the perspective that, we meet patients where they are, we work with them, not on them, and we respect where they are, we respect their autonomy, we collaborate with them. I mean, all these kind of principles that came about, at that time, in the early 90s, were really kind of somewhat of revolutionary things, that, because obviously the field of addiction at that time was improving, we were doing much better, but there was a lot of remnant stuff from the attack therapy, the confrontational approaches, like, in a sense, there were these kind of really, the mentality and the approach was that you have to really, break people down, like to really rebuild them back up, break their denial and their defenses, so they can really, then you can really work with them and rebuild them up. There were these sort of really kind of very, I would say, really compassionate, non-empathic approaches that were really predominant and prevalent in the field, that unfortunately we still see a lot of it now, but I mean, obviously we've really evolved and we want to continue working through towards that. Now let me just, and it's hard for me to really try to encapsulate 25 years of progression and evolution of an approach, and in like 45 minutes. I mean, that's really, very, very challenging. But I want to review a little bit of the concepts, important concepts before we talk about motivation interviewing. And these concepts are really very important to understand because they have really, in a sense, been really important to really understand how MI was conceptualized. So I'm going to use the word MI now, as a really abbreviations, for motivation interviewing. So the self-perception theory is particularly when we're thinking about, and this is back in the 70s, that it is so important when people verbalize a particular position, the more likely they're going to commit to it. And again, this is where, also respecting the person's autonomy and where they are with what they think about what they want to do is extremely important. So again, the Ben's theory was that individuals come to know their own attitudes, emotions, and internal states by inferring them from observations of their own behavior and circumstances in which they occur. So this is really very applicable theory in that context. The second one is the reactist theory. We know that, this has been very well established too, is that the natural human tendency is always to reassert one's freedom. It's like, in a sense, I'm going to start defending myself when this freedom appears to be threatened, even if it hurts them. We see that a lot in medical settings too. We know very well that patients, for example, I go back to examples of people who have diabetes and medical illnesses, is they know what the consequences of their not managing their diabetes well, or the poor self-management. At the same time, they also try to assert what they are doing, even though they realize what they are doing when they are not really managing their diabetes well, that it hurts them. But they still have that kind of really, tendency that they want to argue back whenever you attempt to argue with them about why they need to make a change. I mean, this is really kind of, in a way, more, in a sense, as a theory, it makes total sense. Two important things in our language, and this is what MI is about. It's about really the language particularly, and I'll talk about it, is two really important type of really speeches, like we call them, either change talk or sustained talk. And just to pay attention to what you say and how you say things, they are a part of a natural language that we have. Is the change talk is any time when there's, we call it also preparatory talk, when any sort of statements that people make or any sort of speech that favor movement towards a particular change goal. It's a movement toward. It is not, doesn't mean if I say I want to quit smoking or means I'm going to do it. If I need to quit smoking, these are the reasons. This is a movement towards, and then I'll tell you how it gets to a point where a change happens. The sustained talk is basically the opposite, when there's a speech that favors, the status quo, and rather than movement toward the change talk. So this is, and again, it doesn't mean that people really use that sustained talk, that there's something wrong with it. Obviously, they use the sustained talk when they are not really, ready at this point in time to make a change. And so again, we don't want to really, in a sense, demonize, the change talk. We want to really look at it as, indicative of where people are in terms of the change process. So what really, how people change, and we have that in terms of really the prediction, what is predictive of change is not to really have change, to express change talk. And the change talk is we use a lot of acronyms in MI. One of the acronyms here is the DARN, the DARN cat. The DARN is really more the change talk, the desire, the ability, reasons, and need. When people express the desire, express the need, and they express that they are able to do it, and they give the reason why they want to do it, it doesn't by itself translate into change. What translates into change when people make these statements, and you strengthen these statements, and you start saying, well, I need to change, and this is how I'm going to do it. I am getting ready to do this. I'm preparing myself to really quit smoking, using whatever, the behavior, to keep taking my medications. So there is the next step, which is what we call the CAT, under the acronym, of a commitment, activation, and taking steps. So you have to hear a commitment language that's going to really be, I promise I'm going to do it. There's a difference, for example, like a weaker commitment language, I'll talk about it, is that I think I might really quit smoking. That's different than saying, well, I'm going to quit smoking. We have the whole psycholinguistic is really crucial, and we have a ton of studies that have looked at that. And the activation is important also in taking steps. The activation is that I have started thinking about really, doing that because I want to stop, because I know if I do that, I'm going to stop. I'm going to be able to stop smoking. So again, we need to keep paying attention to that, and that commitment language is predictive of change. So in a sense, every time we're going to be with patients and we're going to hear, change talk, what we want to focus on, and this is what MI does, in fact, it strengthens that change talk to push it towards commitment language. And this applies, there are studies that have applied that also in CBT, cognitive behavioral therapy, really these same principles apply. So this is not just really to specific to MI, but the commitment to change a particular behavior to follow through depends a lot on basically the strengthening of the change talk and the commitment language. I'm going to give you some sense of some of the strengths of the commitment language. It goes from the weakest to the strongest. It's different if I say I hope to change this, or I will change this, I promise, I shall, I give my word, I assure. So in between, you have this kind of like a moderate, to strong language, which is really, I expect to do it, I consent to do it, I resolve to do it. So again, we need to really always be prepared to really pay, to really pay attention, to listen to that language, because this is what's gonna really, get you to really figure out what you want to do with it, and how you want to really strengthen it. And again, this is where the challenge is, that you cannot do any of that work unless you listen, and accurately. What we call like the listening with the accurate empathy. So it's really kind of these listening skills, really basically can be learnable. The empathic listening skills at the same time, they are not easy, to learn. So here, that what I wanted to think about is that, people are really individuals and we are imperfect. Let's put it this way, and particularly when we talk about people who have really addictions, and we have to always remember, the cultural context of the patients, the people that we work with, and always remembering not to make any assumptions, and to go with, Steve Rolnick would say that go with when you're in a clinical encounter, unclutter your mind. Just get to clean it up from all these kind of contaminations when you're with a patient, and then just listen and be there and really be present, and this is really important, because this is what's going to convey the understanding, and really through that whole process, it's going to convey whether you're really there with the patients, and willing to really meet them where they are and really understand them from where their perspectives are. Because our tendency as healthcare practitioners, we want to go and really impose what we think is right for them, what we think, what we believe they should do, they should not do, they need to do, they have to do. All these kind of things, really happen a lot. And again, with the whole building and the engagement, as we talk about really collaboratively working together with people, not on people, and always remembering the personal responsibility of the person. That who's going to have to either do make the change or not make the change. And yes, we are the experts when it comes to the particular field that we're addressing, but we are not the expert on the patients. The patients are the expert on themselves. If we're going to really take that stance where we're really kind of walking into that really clinical encounter, and we're really going to be presenting ourselves as really the authoritarian, and I'm the expert, I'm going to tell you what you need to do, and you have this problem, this is how you're going to fix it, and if you don't do that, this is what's going to happen. And a lot of what happens to also that healthcare practitioners use a lot of scare tactics. Wow, if you're not going to really stop smoking, you're going to end up with lung cancer. If you're not going to manage your diabetes, look what's going to happen. You're going to lose your sight, your vision, and all this. So, I don't understand what that whole crazy idea came about, to really terrify or terrorize people, and believing if we do that, people are going to go and really change. They're going to have that kind of an epiphany and then say, oh yeah, because you told me, this, and I'm going to go and really change. And the other really, however, the other side of it is that, sometimes patients present with a lot of these consequences and they want to change, and the practitioner can say it in an empathic way, how much they are concerned about, and something, they'll take that advice. Say, wait a second, you told me before that if I really gotta continue with the same behaviors, that I might end up really with all these negative consequences. I want to change now. So what I'm talking about here is the approach. Yes, that if you have a trusting relationship, and if the practitioner says it in the appropriate way about their concerns, is different than, and it's going to have an influence, positive influence on the patient's behavior, but the influence does not happen if you're going to use a very much a derogatory tone, and even without meaning it. Unintentionally you could do it, and angry or derogatory tone, and then this way it's will in fact it will backfire, and then they would be less trusting. So we still haven't talked about MI yet. It's coming, just in 2 minutes. So, that is the whole thing. I mean, understanding the context is extremely important. And it's just the whole idea that we have in our systems of care is that we have no time to listen. There is no way. I don't have time for listening. And something, think of it as it's just more the paradox, of if you if you have, let's say, 10-15 minutes and you sit with a patient and then you listen, they're going to feel that you spend more time than the 10-15 minutes that was assigned to that really, encounter. And the other way around, you can sit for a whole hour with them and you're not listening, and they're going to leave saying, wait a second, you just barely, they spend barely 10 minutes with me. So I think it's just the whole idea is that it makes such a huge difference how our demeanor is and how we approach, the encounter. And again, always remembering that we use a lot of the words like walking together with the patients, instead of really trying to be there and trying to fix their problems. In fact, patients are very resourceful, and when you really stop tapping into their own resources, you're gonna see so many patients, coming up with their own solutions and really options, that can help them. And this is an important concept, that the ambivalence. And what you obviously have, and which is ambivalence is normal. People struggle with really the two sides of the coin, in the sense, one part of them wants to change, the other part of them doesn't want to change. And eventually, people are going to have to resolve that. It's to live with ambivalence is very painful. People get conflicted and eventually they have to tip the balance. And two things, I talked about the self-reactance theory before, but the righting reflex, which is very, very activated in medical settings, which is really that desire to fix. I sit there and I wanted to fix their problem, or really feeling that I'm gonna, okay, this is what your problem is, and I'm gonna give you the recipe for change, and you're gonna do it, and if you do it, everything is gonna be great. That is really always, unfortunately, very activated in medical settings, and if you put it on hold, and you really kind of respect where people are, instead of going there to trying to fix them, and fix their problems. And I remember I had a mentor who, early on, in fact, the mentor who introduced me to MI, he told me one thing, that, look, try to really go with the attitude that don't take credits for the change they make, and do not blame yourself for the change they do not make. Be there as the catalyst for the change, and let them really take it from there. And again, this kind of goes back to the point where, this whole tendency is that we want to go and really fix and fix and fix, and then we will be totally disappointed because there is no way we are able to fix, people's problem. I give a typical example here, where you always present, the situation where I'm going to show you that what you really, like, in a sense, trying to really, argue, or trying to really win an argument. And this is a huge problem. When we go with the attitude that we want to win an argument with a patient, we will always lose the argument. Look, for example, they tell you, well, smoking causes a cancer, it will kill you. Well, they say, well, I don't think so. My grandfather lived 90 years and smoked every day. It didn't kill him. Again, so there is this kind of a tendency that we want to really, it's like, who doesn't know, for example, like, smoking, doesn't kill you. Really, is it about educating people? So again, always remembering, there is we want to keep tilting the balance towards that change talk, because we want to help people resolve their ambivalence. It's up to them to resolve that ambivalence. Without resolving that ambivalence, there is no way that they're going to really proceed with any sort of change. So let me, I'm going really here. This is what happens with the righting reflex. With the righting reflex, the desire to fix, what ends up really happening is, that people feel totally invalidated. It's like you're really ripping people off from their own autonomy and decision making. And what's going to happen, they're going to feel not really heard, not respected, and really more angry with themselves, more ashamed about their behaviors. And then what is going to end up happening is that they're going to argue back. They're going to really start getting more defensive and oppositional. And the end result of it, they're going to detach, from you, and then they will never even come back. So basically what ends up happening, the outcome is totally negative. I'll talk about really the different, the MI style, which is the empathic listening style. So, the one thing is that we're in the third edition now of MI. 2013, third edition came out, after 25 years of incredible work that has been done in the field, all across behavioral medicine. And we try to define it from different perspectives, from the layperson perspective, the practitioner's perspective, and the technical perspective. When we're talking about really what the layperson perspective is, that we're talking about really a style of communication or collaboration, but also just a conversation about change, as simple as it is. We try to avoid labeling it as a psychotherapy approach, because again, you use that kind of also language with a lot of people. It's like, wait a second, oh my God, I need to really learn another psychotherapy approach. This is it's not a psychotherapy approach. It's basically a particular style, a counseling style. And the whole point of it, the whole really goal and really the aim is basically to strengthen the person's own motivation and commitment to change. So this is what it is for. So from the practitioner point of view, is what we're doing is we're focusing on the ambivalence when it's there and helping the patient resolve that ambivalence. Because if they haven't resolved that ambivalence, they would not be able to take any steps, towards a change. So the technical piece is the more obviously elaborate piece, that this is how it is really learned, and it takes, obviously time to learn it, time to practice and get supervision, which is exactly the few words that are very important. The collaborative, still really goal-oriented. This is a very, in a way, directional, style. You know where you're really going, in a sense, what particular area you're trying to address, and it emphasizes a lot on the language of change. And I talked about the change talk, remember, the commitment language, sustained talk, and particularly what is really important is that when you're with the patient, this is what we describe the spirit of MI, is that you're present and you're really, in a sense, conveying, the acceptance for who, for not the behavior, for the patients, for who they are. If I don't know how many of you are really familiar with the Rutgerian approach, the client-centered approach that, about talking about the unconditional positive regard, the genuineness, your being there, and obviously as a part of it also comes really the atmosphere of acceptance and compassion. It's just easy to really kind of talk about it, but when it's really in action, we have so many of our own really preconceived notions and judgmental attitudes that could contaminate the process. But I think if we are there and present and putting aside, all these really contaminations as I described them before, then you're going to be more really present, more listening, and more really, providing that acceptance atmosphere. So what do we define as so you have the spirit of MI, which is really what we call more the relational piece, that collaborates on collaboration, evocation, and this is crucial. The MI is based on evoking from people, which means bringing from within all the way out. So you are not imposing, you are basically evoking from people. To evoke is really extremely important, and it can be very, really powerful, because what you're doing, you're really trying to get them to identify their own resources and what they really want to do. And at the center of it is basically respecting their autonomy. We have a hard time with that, We have a hard time when we see, a lot of patients who engage in all these destructive behaviors and they keep doing it over and over again. It's like, what's going on here, Obviously, patients, get stuck. And patients get stuck for many reasons, and we want to kind of get some better sense of what keeps them stuck and really help them really see if they can unstuck themselves. And a big part of it, as I said, if you don't accept that people for who they are and accept they are capable of change, I don't know what you would be doing with patients. I don't know what sort of work you can do with patients if you're not going to be there and accepting that patients are capable of change. you know. And again, I'm not talking about here giving people hope or instilling hope. I'm talking about evoking that hope from them through the whole process. And the whole spirit of the compassion, as you know, we talked about really, this is really, I mean, it's a kind of a more of a, you know, it has a component or concept of really a type of love, really, you know, I mean, and again, we're talking about the different really dimensions of love. I'm talking about, you know, the love in the therapeutic relationship is really based on that compassion and based on really the genuineness and based on really the caring, you know, and let's keep that in mind, you know, and not really be kind of, in a sense, you know, intimidated by really kind of conveying that, you know, and the concept of really the Christian concept of the agape, you know, we'll talk about the love, you know, and how love is defined, you know, and obviously, you know, big part of really the MI approach is really based on that sort of really, you know, caring and really, you know, being concerned, you know, about people's, you know, health, you know, and really, and being concerned about the person, you know, and being present with the person. And this is totally the opposite of the non-MI approach, which is really the whole attack, confrontation, education, and really, you know, having that authoritarian approach. In fact, in MI, you know, the encounter is really very much of an egalitarian one. So you have the spirit, which is the relational piece, and you have what guides the spirit is what we call the fundamental processes, which means how you're going to conduct the whole process. And you know, and there are 4 processes. Obviously, I talked about the rapport, you know, building initially, and the engagement. Engaging is one of the first processes. You're going to have to establish that therapeutic alliance, which is really non-specific to MI in a way. In any sort of a clinical encounter, that therapeutic relationship has to be established. And the second one is the focusing piece, which is you have to have a strategic focus, what you're really addressing, what sort of particular behavior, the directional aspect of it. And the third one, which is very, very specific in a way to MI, which is the evoking part, and I'll talk about it. And obviously, once you start evoking, people have started really resolving their ambivalence. Obviously, the planning is really the commitment to really the change. So you have the spirit, which is the relational, you have the processes, and so what about the technical piece? How would you go by to do MI? And these are the foundational skills. The foundational skills are really kind of under the acronym of FORS, you know, which is the open questions, you know, the affirmations, not cheerleading, affirmations, and the reflective listening. You know, and reflective listening is at the core of the accurate empathy. And this is one of really the most difficult skill to learn. You know, but you cannot really reflect, you know, and what you're reflecting, you're testing a hypothesis. You're not interpreting. So when you're reflecting and testing a hypothesis, you know, it might come across initially as easy to do, but once you're really trying to do it and you're paying attention to or listening, you know, it makes it really very challenging. And the fourth one is a summary. The summarization is basically, it's like a collection of really reflective statements, you know, and to help you transition from one topic to another, or to really kind of summarize, you know, what we know about what the patient already shared. You know, let me kind of, again, this is important. We have a tendency in our healthcare to do a lot of cheerleading. Good job, fantastic, you know. And we have a tendency to think of it as whatever they are doing is satisfying or rewarding us, or we're really feeling good about what they did. Well, it's not about us. You know, I can feel good about what they did, but how do they feel about it themselves? And when I affirm, it's more about acknowledging what they did and how they feel about what they did. I mean, as simple as these kind of things are, we have a tendency to always revert to bad habits and want it to cheerlead, you know. And again, this whole thing I talked about, the scare tactics, that if you make people feel bad enough that they will go and change, you know, and in fact, you know, affirmations, you know, can really empower people so much, you know, that they can reflect on their accomplishment and what they've done, and that can be by itself very much rewarding for them. And as I mentioned, the reflective listening, which is really big challenge, you know, to learn, you know, I mean, again, it's that collaborative, non-authoritarian, you know, thing, and then keeping in mind that it is always a statement, never a question when you're reflecting, and your tone of voice wouldn't go up, your tone of voice would go down, and it has more of an invitation. When you're reflecting, you're inviting people to open up and share. When you're asking question, might not really work as well, obviously, but obviously if you ask an open question, or what we call like an evocative question, what you're doing is you're really kind of expressing that, what we call the curious and itchy mind. Steve Rolnick talks about that. Like, I want to know more, but I wouldn't want to know more unless I try to ask an evocative question. And again, it comes with the non-judgmental, non-confrontational, and it does not by itself give a direction, or an advice. That's very important to really keep in mind. And always remember, if you want to give an advice, or if you want to really proceed with giving a suggestion, an observation, always to ask permission before you do it. Because when you ask permission, you're respecting the person's autonomy, and you're basically, also I always really preface it by the fact, look, I would like to make an observation. It might not be the accurate one, or I like to share with you an advice about, based on my experience working with patients, doing this and this, would it be all right with you if I share that? And again, it's up to you. This advice might not apply to you, and I appreciate you telling me. If you don't feel like it's a good, really it resonates with you and it really works for you, well, we'll look at other potential suggestions or advices that we can figure out more what you believe works for you. The whole concept, this happens in a lot of the therapeutic work, I don't know if any of you have heard of the, I believe so, Equipoise, the concept of equipoise and equanimity, also. And, it's not a therapist attitude, it's exactly that counseling with neutrality. At the same time, you're not a neutral supporter. I don't know if you understand what I mean by that. So when you're really kind of, for example, a lot of situations where, patients come to you and, let's say, for example, a couple who's struggling with, the spouse wants to have a kid, the other spouse doesn't want to have, the partner doesn't want to have a kid. So what do you do here? You're going to really try to have one spouse convince the other one, no, we should have a kid, no, we should not have a kid? Or how can I really be an important, really, approach to help the couple resolve, their really conflict, and which can be very painful, and so this is where the counseling with neutrality is to really elicit from, each side what they think and really have them work it out without you really trying to influence an outcome. And this is really very tough for us, in medicine, and because we want to feel like we want to influence. Yeah, you're going to eventually influence the outcomes through what you do, but you're not influencing the outcome by really making decisions or telling people what to do. So again, this is a really big challenge because you're going to try not to influence a person's direction or choice or change. At the same time, there is a part of us in the MI, for example, as an aspiration, for a practitioner, is that I want to make sure that the patient is going to, resolve his or her ambivalence, and because I want them to really stop using drugs, let's say. At the same time, how could I really kind of, and I know that we're really promoting health when we're patients, but how could I really do it in a way that is not my agenda? Because I hear a lot of times patients who say very clearly to me in my face, look, well, I don't want to quit using. What am I going to, I'm not going to quit using. I always say, well, I respect your perspective, would it be all right with you if we have a conversation about where your perspective is, about it, everything, instead of really going with the intention that you really want to do it. And, so the question has been always, do you want to proceed strategically to address that ambivalence, help them resolve it, or do you want to maintain that equipoise and not intentionally or inadvertently steer the person in one particular direction? That's a huge dilemma in the work we do all the time. So the question is, when MI initially came about, it was originally developed, for the formal situation, and so, but where is it really? How can we really manage to bridge it? Because MI is also some sort of a counseling with neutrality, and the equanimity concept, which is, I'm not sure how many of you are familiar, for example, with the Zen, approach, the Zen, the mindfulness and all this, that they talk a lot also about the equanimity aspect, which is really, look, we recognize our limitations in our ability to change people. At the same time, if we can be present with people, that by itself could mobilize people in the direction they want to go towards. And this is where basically they have that kind of a challenge, is that we want to really figure out, okay, what we want to move with our aspiration, evoke more towards really the change, and then, or we would want to really kind of tilt it towards equipoise. This is something you would have to decide based on the situation, based on the individual clinical context. You would have to figure out where to go. And we have some, in certain situations, like cultural context, we have patients who really, would ask us specifically, "Doc, what do you think I should do? Should I take my medications? Or, what do you say?" You say, "Look, I'm not going to tell you what you're supposed to do." Well, that could be insulting to some people, because they trust you in giving your opinion, because, they really respect, how much you know, and that you're really the fact that you're with them. So what would you do? You would want to give that opinion about what you think, at the same time always remembering that, look, I really appreciate that you asked me what I think and my perspective. At the same time, I want to also tell you what I think. You're the one who will eventually determine whether really this is something that will really fit with you. So this kind of goes into really, you want to evoke more, you want to give, you want to be actively participating and helping them with their decision making. At the same time, you want to keep a little bit of that, neutrality there, so you won't be impeding, you won't be really interfering with their autonomy. It's just it's a challenge. So, but obviously, both choices involve the equanimity, they involve the collaboration and the respecting autonomy. They do not conflict with each other. So this goes to really what I was just saying about the impact of the righting reflex versus the listening and the evoking and the empathic style of MI. As people, when they are affirmed, they are more like feeling accepted, they are really, they are really more open, they are really less defensive, they engage more, they stay in treatment with you, they really respond better. I don't know, if there are a lot of people who are skeptical about it, we've had that. Let me tell you, we've had, now we're in the hundreds, we have more than 250 randomized trials. We have a ton of really trials that have been done, all across range of population settings, behavior, culture relevant, and just to give you an idea, this is up to really 2009. Look where we were with the addiction, which was more of the addiction, in the addiction field. Look where we are in behavioral medicine now. In dental settings, in the, different settings that you can imagine, where any sort of really basically context, for behavior change is applicable, MI has a role. And this is really important, how to define really, to put it together really as, with MI is the cross-cultural encounter. There's always a cross-cultural encounter. There's a little bit of an adaptation here that I use, is that with the triangle, obviously, they all really kind of merge together, whether obviously the empathic collaborative approach, the respecting also people's autonomy and accepting them for who they are. And at the same time, you wouldn't know who they are unless you have that sort of a curiosity that you want to know who they are. And you want to be able to really understand them better. So they are really very much, these three pieces are very much tied together. If you're going to go with the attitude that all you want to do is really collect data for whatever really purpose, diagnosis and everything, that without any sense of curiosity about the person who's going to give you the data, you're going to be really not really, the outcome is not going to be really what you would be expecting. And this is really from a couple of, just to finish up here, how treatment is delivered, matters. And what matters mostly? The relationship. This is what we have learned from years, 30 years, of addiction, treatment, particularly. And this is what I want to talk about, is that when there's a confrontational approach versus the MI approach, how you see more of a change talk versus the sustained talk. So if you really, and this is really well established in the field of addiction, but also established in any sort of a therapeutic encounter. And this is where I talked about it earlier, Frank, the study, about the HARP study, about, how much it's important, your own beliefs and expectancies of whether people can change or not. This is the Pygmalion, effect, the study from the 1970s. It's an amazing study, and it applies all across, any sort of work we do with patients, that if you really believe in the patient's ability to change, they will more likely change. They more likely will improve. But if you're going to go with the attitude that they are not going to do it, and this study basically looked at what we call the HARP, the high alcoholism recovery potential, and they assigned these counselors and they told them, look, this group of patients are very highly motivated to change. They want to quit drinking. They want to have a better life. They want to have a job and everything. And we tested them. We used specific psychological testing. And please go and work with them and let's see how they're going to be doing. So they ended up going and working with them. In fact, these patients, that group of patients do much better on all levels. And they did much better, 6 months, 12 months, and guess what, the whole thing of they say the secret of the study was that these patients were selected randomly. There were no psychological testings were done. And in fact, so the counselor's expectations matter so much. And something? Expectations are self-fulfilling prophecies. And we see that all over, with any sort of a treatment settings where I have a lot of patients, unfortunately, who are caught into these self-fulfilling prophecies that they are not going to do well. If they are not going to do well, this is the same problem. They're going to go through the same thing. And then that kind of really affects their motivation for change. And we want to address it, with patients all the time that, being caught in that self-fulfilling prophecy, thinking is really very destructive. They would want to really go and break through. So just 3 more and then done, that the question is why train in motivation interviewing? Well, I've already told you what I think, and why it is really essential, but fundamentally, I think what is really a struggle that we have in that field, let's talk about the diffusion of innovation, all these, new approaches, from way back, is that the fact that, there is no, 2 things that are very important. First, you want people to believe that this is important for them to learn. I mean, I can sit here and tell you, oh, let's go and do workshop and coerce people and force really, your staff to go and learn. But they go really and they with an attitude, it's like, why would you want me to do this? And I don't want to do it. I've been practicing for 25, 30 years. Now you're going to tell me I have to change how my style is? We never say that. We have to be clear. You're learning an approach that does not mean it should destroy your identity as whether a counselor or a physician, or in fact it can be really very much it can merge very well with who you are as a person, what your style is, but there is no attempt here to really change who you are or change your style. Obviously, as I mentioned earlier, the informed consent, it did change me, but it didn't mean, that I had to change, my style and how I did it. I just changed my style because I believe it's important for me, and that approach helped me do it. So again, keeping that in mind and always remembering that can be integrated in different ways and the brief motivation interventions are really basically adaptations, and so people can learn in different ways. 2 things to learn it: practice and supervision. There is no other way to really learn that approach. And there is 2 types of practices, guys. We can really practice, go through the motion, and repetition of the skills, unstructured, or you can practice deliberately. And you always really pay attention to what you're doing. You have that what we call, like they used to call it in the psychodynamic word, internalized supervision. Like you go for that external supervision, but you also reflect on, you did this session, well, let me see, why did I do this and how did I do, what my skills were, what really, changed here, could I have been more empathic, why I was confronting this, and that is really very much, you're pushing yourself to restart practicing more deliberately. Unless you really go and then you're going to have to do whatever you have to do and move on. And so keeping that in mind, without really deliberate practice, there's no way you're going to learn to do it better and better. So, these are this is the 3rd edition of the MI book. We wrote a book, 2 years ago, and God, it's almost 2 years ago. This is the MI, it's a guide for medical trainees. That was the labor of like 3-4 years. And in fact, it was written by medical trainees who worked with me and the other editors. And then we basically edited the work that they did. So it was more of that experiential experience that they really shared about their training in MI and and then we put it together. And it was really great, also another humbling experience for me to really work with trainees, and get them to really do that work in a sense, and us really doing the editing piece here. These are the disclosures, I believe. So, and that's it. Thank you.
us to get Dr. Douaihy back to the airport to catch his flight, but we do have about 10 minutes.
Yes, please.
For questions, clarifications, and so I want to open it up for that.
Yes.
See this working with children?
Yes.
Or adolescents?
Yes. Okay, good question. So it's children and adolescents. Well, first of all, there are some studies, adolescents, for sure. Let me talk about the children. The age, you need some sort of a cognitive maturity, to be able to negotiate, some sort of behavior change. So a lot of the studies look at really the middle school children. I mean, like we talk about, like, if you think of it like around the age of 12, 13, 14, you can get started with the whole process. It can be adapted, in a sense, and because you have to adapt the language, and which means, this is similar to, a lot of people ask me, well, can you work with patients who have psychotic disorders? Use MI. Of course. But, you have to change the language, adapt the language so that can be easily understood. Because obviously, it has a big intellect, you have to be intellectually present, cognitively present. But kids at the age of 11, 12, so 11, around that age, are capable. Because if we look back, a lot of the behaviors that they exhibit happen around that time, or the risky behaviors or something. So I think you could really start doing the work at that age. I mean, earlier age, might be challenging. We don't have studies around that. With adolescents, we have a ton of studies. In fact, a lot of really DMI has been utilized, integrated with CBT, integrated with other really therapeutic approaches. And in different fields, in depression, not just really substance use disorders, depression, like mood disorders, behavioral disorders, a lot of basically, a lot of the risky behaviors and all this with the adolescents. So it is well established, and there is a lot of really work that has been done in that field. And for example, also there are more and more studies now looking at the use of MI in adolescents, suicidal adolescents, and how you could really elicit, the reasons for change, and for wanting to live, and so modify. And the thing is with it is that it is not necessarily by itself the only approach. Most of the time, it's been always very well integrated, with other approaches. For example, depression. In the context of depression, even in adolescence, MI has been used more as a prelude to treatment. Because we always assume people who come to treatment are highly motivated to really do CBT, to do the work. Really? I mean, most of the time, a lot of people struggle with the motivation. You're expecting them to do all these homeworks and all those. So you do that kind of a prelude session with MI to really, move the motivation. You do whatever behavioral therapy you want to do, and then you boost it later on with another MI also to really kind of make sure that the motivation is still, and particularly identifying if the motivation starts really, dipping, to really kind of really strengthen it, with some motivational strategies. Yeah.
I have a question. What do you think is the next frontier of exciting research for MI? Where do you think it should go, or what's getting you excited about next steps in research?
I love this question. Where is the next step, in terms of the MI, the research, and really what we would like to see happening more? Obviously, I don't want to see any more things happening with the field of addiction. We have resolved that. We know that MI. Whereas what we want more when it comes to the research is the two major challenges for us now that we've established, the approach is the dissemination and implementation. We need more studies in that. We need more really models of training, that work. We need more models of supervision, and because I mean, obviously there are more. There's an explosion of research in different areas. And again, would I want more randomized trials? Of course, I want more. I mean, we just finished basically a trial recently, kids, adolescents with bipolar illness. We looked at basically with Tina Goldstein.
Yeah.
We looked at really basically adherence to medication, and it's really adolescents with bipolar illness. Their adherence to medication is really disastrous. So we looked at a brief motivational interviewing, sessions, versus really the treatment as usual. And it's fascinating. We found out, that the adolescents who have the lowest adherence responded the best, to the intervention, and that they increased their adherence. Well, the question is, okay, we did the study. It's an R34. We finished it. So now we were kind of debating, so what are we going to do next year? All right, well, we demonstrated that. Are we going to need to look at the mechanism of change? Do I want to know? I mean, people changed. Why do I need to keep looking at wanting to find? Or could I really figure out a way to disseminate that? Because we have a lot of child and adolescent psychiatrists, who basically struggle with that. How can we really train more of these counselors in these, or how can we do it also really via, telepsychiatry, how you can really get them to really do it and supervise. And so we're trying to come up with these creative ideas instead of always thinking of it as research. How can we translate it into the practice and how we can get people to do it, and what sort of really approaches would really, or training models that would really work. And this is a big, big challenge, and we're still working on it. Yes?
Thank you very much for your second lecture.
You're
Really
welcome,
good.
thank you.
So, as you were talking, I think that for us the challenge with the medical staff is that supervision piece.
Yes.
Because it looks easy, it's not. We
Yes.
know that it's not. Using an echo model
Yes,
to do
yes, we
that,
have, yes.
are you studying that? How does
Yes,
that come
I think
about?
that's one of the models that could really, yes, exactly. The thing is that, first of all, you're gonna have to, we were talking about it, having champions. This is not just one person who's gonna do it. I mean,
And we work with that model, by the way. We want the champion.
yes, we were just, so, I think I think the key issue they need to remember here, that when you are presenting it, and with these models, with the echo model, which is, what you are looking for is not to get people fully proficient. Like, you don't want people to be, I mean, we don't use the word experts in MI, but you don't want people to have these really so much advanced, skills. They don't, I mean, you wouldn't need that. You want people to have these basic and the skills that they use that they're gonna consistently apply. And this is where the problem is. And this is what the supervision provides, is that consistent, application of the skills. But the biggest reason why it doesn't happen is it's more of a cultural, I believe. It's more like the setting. Because again, the people can tell you, well, I don't have time to listen, I don't have time to really, I need to collect. I mean, there's always these kind of reasons. And if we look at, for example, in the field of addiction, we know that the therapist attributes are really fundamental, to changing, to really improving outcomes. Not really the specific therapeutic approach, not whether it's CBT, relapse prevention, or it's just more, if you have the empathic skills, if you work collaboratively with patients to respect their autonomy, which is basically exactly what DMI is about. Yes, I mean, then I think we would wanna, what we're trying to do, and we're trying to infiltrate a lot of these rural areas, where it's very hard, they never really receive any sort of training in that practice, is to de-intimidate or to really de-stigmatize it as an approach that is so difficult to learn, and to really kind of making it look, as Bill Miller, we used to say, it's a way of being. I learned a way of being.
And that's the challenge. I think
Yeah.
that because for doctors, for that
Yes.
medical,
Yes.
we're so into that expert trap.
Yes, exactly, all the
And
time.
it's hard to just get
Yeah.
away from it. We want to impart education, but we should ask permission.
Yes.
How is it that we can step back and
Yeah.
allow that person to let where are they?
Well, we need to humble ourselves.
There we go.
That is where the problem is, and
Expert
again,
trap is bad.
yes, I mean, it's a big problem, but I think people change.
Yes.
If you really, and something also, I avoid, the showing them how it works, all the randomized trials. I don't just, I just more discuss these basic principles. And I always tell them to really think themselves if they want to. I always really challenge, when I'm doing any kind of workshop, challenge them about changes they want to make. And I gave the example, typical flossing, dental flossing. What, 2 minutes? How long does it take? And you can do it once a day. How many people do you believe, over the course, consistently over the course of 3 months, do it every day? What's the percentage of people you think that would do it every day over the course of 3 months? Once a day, for 2 minutes flossing.
5%.
But it's 30% basically. 30%. 70% don't. But you see, the tiny behavior like that, people cannot even handle it.
Yeah.
We cannot, so how are you going to get people to do it? Going and telling them, oh, go do it? Why you're not doing it? You go to the hygienist, tell you, oh, you should be flossing, and you're not flossing the right way, you should be doing it this way. And where you basically know, In fact, a lot of people, what they do before they go to the hygienist, like 4 or 5 days before, they go and start flossing before. So I wouldn't be told, look, you're not really taking care of your really. So, and then after they go back to the same behavior.
That's true.
I promise you, we'll find other opportunities to bring Dr. Douaihy back
Yes.
under different circumstances, but I think for now we have to let him go. So.
Thank you.